This meeting is being recorded.
Good morning, everyone. We're going to give everybody about 5 minutes to get here, and then we'll get started. People are slowly trickling in, so we'll start in about 3 minutes.
Well, good afternoon, everyone. My name is Ernest Walker, and I am the Senior Manager of Capacity Building here at Help HIV. And today, the Effi Institute is going to have the distinct honor of having Dr. Hogan come in and do a presentation on HIV and aging, the graying of HIV pandemic. So this program is funded wholly by or part by the government of the District of Columbia, DC, Health, HIV/AIDS, Hepatitis, STD, and Tuberculosis Administration, also known as HOSTA. So the Epidemic Institute, what is it? It's a regional training. What do we do? Regional trainings, individualized technical assistance, the individuals who we will be providing this for are current and prospective HOSTA grantees and community-based organizations. And how will we be doing this? Group level trainings, boot camps, community forum, individual consultations. And then there's a variety of topics. These are just a few. These are not limited to these. We have a lot more, but we're providing, fee-for-service business process, basic HIV service competencies, advanced skills in healthcare systems, data and health informatics, and high impact prevention programs. And then here are some of the things that you'll see when you go onto the Institute website. Again, the website is the effiberryinstitute.org website. You'll see provider modules, webinars, Ryan White, program policies, tools, and resources, and a training calendar. And you also have the opportunity on here is to ask questions and get responses from the staff here at Health HIV. So, Dr. Hogan. So Dr. John Hogan is a graduate of Brandeis University. He attended the medical school of Howard University College of Medicine. He completed a residency in internal medicine and a fellowship in gastrointestinal diseases at Howard University Hospital. He is currently employed by Unity Healthcare at multiple facilities where he provides primary care and healthcare services. Dr. Hogan is also the medical director for RAP Inc., which is the oldest residential substance use treatment program in Washington, D.C. metropolitan area. All right, without further ado, I give you Dr. John Hogan.
Thank you, Mr. Walker. And I'd like to thank first the organizers of this event for inviting me. Excuse me, my sinuses are getting to me. For inviting me here, and I'd like to thank the participants for taking time out of their busy day. As it says, I work for Unity Healthcare, where I work at Parkside Clinic, DC Jail, Brentwood Clinic, and I'm also the medical director for Regional Addiction Prevention Inc., RAP Incorporated, which is one of the oldest residential abuse treatment programs in the United States. I'm there. I've been at Unity for 29 years. And I've been at RAP for 25 years. So I'm like a stray cat that you feed. Once you take me in, that's it. That's it. I ain't going nowhere. Here you have my disclosures. I am a speaker for both the companies Gilead and Merck. And I want to pay you to pay attention to the fact that I have no stocks, none. If any of you can help me, please get in touch with me after this program is over. I need help really, really bad. Next slide. First, we have here that there are gaps in our understanding of the changing demographics of people living with HIV. And two, it says that there are gaps in our understanding of the impact aging and aging and other comorbidities have on people living with HIV. And here we have an elevator that didn't quite fit, and it's telling you, be careful when you step off, watch the gap. Next. Learning objectives. We're going to review some clinical vignettes and data that's going to fill in some holes and gaps in these vignettes. We'll look at the current epidemiology of HIV, identify the impact of the changing demographics in the epidemic, and identify ways providers, case managers, medical assistants, everybody that comes into contact with the patient can help our patients meet their needs. We all play a part in this. Okay, next. Next. The first vignette is we're going to talk about somebody. I mean, the vignettes will include people who acquired HIV after 55 years of age and effective antiretroviral therapy. Next. Oh, I'm sorry. I need to acknowledge the fact that a lot of these slides came from the National AIDS Education and Training Center library, and that this was a slide that was again on HIV and aging, working with this population, and I do need to give due credit to them. So the first patient, 60-year-old man, referred for new HIV infection. He was found to be HIV positive at 89 about a year ago on a screening before surgery. He tells a story of receiving 9 units of blood about 20 years earlier. I wish we were live, so I'd ask you, well, what impact does that have with him being found to be HIV positive a year ago? And I'll tell you that from acquisition of the virus to AIDS take anywhere from 8 to 12 years. Average person, some say 8 to 10, some say 10 to 12, but 8 to 12 years to have AIDS. This is telling us about a possible contact of 20 years ago. And if it involved unit of blood, he got a volume. Think about the amount of blood that's in the remaining from a syringe from an IV drug user, or the amount of little specks of blood someone get from unprotected, from condomless sex, versus get an entire unit of infected blood, or 9 units. Those people back in the 80s were sick immediately. So we can put that over here on the side. He had multiple female sexual partners. We know that's a risk. No history of ID, intravenous drug use, but some of his partners may have. So we know that that is sex with people who have a history of intravenous drug use. He comes to you today with a CD4 count of 244 and a viral load of 123,000. What happens? He presents to the Infectious Disease Institute or clinic as a patient with his girlfriend who is HIV positive. That's something you're going to have to do to pull her aside to find out how long has she known that she was positive, etc. But anyway, that's another conversation, because that means she has viruses, he has viruses. What do they know? Are they transferring this back and forth? Is she on therapy? What do you know about HIV disease? So there's a lot of health literacy coming into play here. This patient refuses to fill out paperwork for ADAP for fear of being reported to the IRS. This is a very big problem for our undocumented people, because ADAP is the federal government, and they feel like if they come under the radar of the federal government, they'll be sent back home. So a lot of people, they don't have insurance and they fill out papers for ADAP. You tell me what's going to happen. And you have talked to them about paper involving reporting them to the federal government. In their eyes, what do you think they're going to do? They're going to disappear. They're going to run, as we would say in Georgia, like a scalded dog. Next. Yeah, so he runs. He doesn't take medicine. He comes back 12 months later with a fever and weakness. CD4 count is 67,000. Viral load is 320,000. Serum cryptococcal antigen is positive. CSF is negative. He's got cryptococcal meningitis. Okay, he started on treatment. 2 months later, viral load is 93. Viral load is down to less than 400. Subsequently, don't forget, he's 60 years of age. He started on a statin. So here come comorbidities, hyperlipidemia. 4 years later, he developed type 2 diabetes, hypertension, arthritis. Now, 20 years later, here we are today. He has a good CD4 count of 500 and over 500 at 504. And he's been on several different medications. So what can we say right now before we go any further? First of all, he presented with an AIDS diagnosis that already puts him at risk for a lot of things that people who come before they develop AIDS, which is a CD4 count below 200, 14%, or before they have an opportunistic infection. He had both AIDS and an opportunistic infection. When we start looking at his probability for comorbid conditions, adverse outcomes. We start talking about mortality. He is at risk for some of everything because he comes here now with an AIDS defining illness. Next. Number 2, we have a 64-year-old man who from an outside hospital with weight loss and confusion. Wow, 64-year-old, weight loss and confusion, has a diagnosis of HIV and AIDS. He has a diagnosis of AIDS with weight loss. And I don't feel good. Depends on how much weight he's lost walking in the door. And he's confused. Confusion, weight loss, maybe mild fever in today, American, African born. I mean, I don't care. Cryptococcal meningitis. You start thinking about cryptococcal meningitis. With deficits, weakness one side or the other, you start worrying about CS. So with just confusion, you worry about cryptococcal meningitis. Recent medical history. He had a history of shingles 3 years ago. Since I started treating people living with HIV in 1993, anyone presenting with a diagnosis of shingles gets a test for HIV. I don't know if they missed this. Just understand, anybody presenting with a diagnosis of shingles for 30 years gets an HIV test. Failing health, sinusitis, thrush, he's got everything. Again, 64, presenting with AIDS. Married, heterosexual, denies high-risk sexual behavior. I don't know what it means. He's married. I want to talk about what you do with your wife. I'm not talking about 50 other people. Okay, I'm talking about you and your wife. Again, I do need to know about what? Other people at risk. You have a viral load of 97,000. And we're talking about, I also have a public health obligation to find out who you've been in contact with, because that's why it's getting so hard. It is so hard for us to get these numbers down. Had a midlife crisis in his 50s and turned to intravenous drugs, meth and cocaine. Wow. Both requiring multiple treatments. I can tell you that. Anybody doing meth, whether they smoke it or IV, cocaine, often requires multiple treatments or prolonged treatment. Just remember that. To try to do it, yeah, AANA, if they get immersed in it, go every day, go in the morning, go in the evening, make coffee. They have to get involved in order for AA and NA to work. Next. Vignette number 2, he comes in with nausea, a rash in his hairline, face, neck, and upper body. BMI is 20. Rash, again, he has tenofovir, emtricitabine, L-vitigravir, cobicistat. He's on a single tablet regimen, all the medicines in one pill. He's on trimethoprim sulfa, sulfa drug, all over rash. I got a question about that. I need to know about G6PD, whether that or whether he has a sulfa allergy. He's also on fluconazole. Don't forget he had cryptococcal meningitis. He's on azithromycin, excuse me, people, because his viral load, although we don't do it now as much as not recommended, but it depends whether you with CD4 counts less than 100, definitely less than 50, whether you're going to start them on weekly azithromycin. A lot of practitioners, my sinuses are leaving me, forgive me, will start intravenous drug users, homeless people who are at risk for other comorbidities, who have low CD4 counts, even though the recommendation says you don't have to protect them because they're at greater risk. His labs is he has a CD4 count of 82. On medication, his viral load is 22, so that's very good. Very good. He's taking his medication. Next slide. Vignette number 3, 69-year-old man, generally well. I like that. He self-caps himself. His BMI is 31.6. What does that mean? Don't look at me. Y'all can't see me. Oh, yes, you can. Don't look at me when I say a BMI over 30 is what? Obese. Okay? That's the way it is. We have a 69-year-old man that's not just overweight. He's crossed the line into obesity. So what does that say? him up for? African American, Latino, Asian, all kinds of different things when we start talking about heart attacks and strokes. His meds, abacavir, lamivudine, dolutegravir. He's on fluconazole, cetirizine, and Pigaba, which is Lyrica. He's on trazodone. He's on odansterone, which is for nausea. What's that called? I have a senior moment. He's on Finstride for prostate, and he's on Docosate for constipation. I wish we were face to face to talk about this. I have a 69-year-old male. If he is a man, it really doesn't matter. All it does is put him for risk for cardiovascular complications and strokes when he has over 50, when he's over 40, he has an elevated BMI. If he has hypertension, all these other things, it puts him at risk. And again, we would talk about starting this man on an abacavir containing regimen because you have increased incidence of cardiovascular events in patients starting abacavir within the first 6 months who are at increased risk. So something to remember. Lab CD4 count is 276, so he's out of range of AIDS, but he's still in a little bit of a danger zone because he's not over 400, 500. And it's good he's taking his medicines, his viral load is undetectable. He's on stable heart, good suppression. Again, his CD4 count is going up slow. That could be just an individual thing. Often you see that in patients who have been here in and out, in and out, in and out of care over 15, 20 years, take medicines and stop. And what is that called? If you all were here with me, I'd look around. What is it called? It's called immunosenescence, having a senile immune system in one that cannot remember what it should be doing. And in this case, it responds just like an older person, me included. It moves much slower, it's less aggressive, all these other things. So again, this man has delayed CD4 reconstitution. Often you'll find someone who came in with a very low CD4 count or one who have been in and out and had AIDS for an extended period of time. They call it immune exhaustion also. His main problem is urinary issues. Next. Here we have the estimated incidence of HIV among Black American males greater than 13, 2010 to 2019. And we see that for the youngest group here, 13 to 24, it's going down. And the group that you all are to focus on is all of them for African Americans, number one. But your highest census is those 25 to 34 because it's increasing. And the others are remaining pretty stable. So we need to focus on 25 to 34. They think they're going to live forever. They're spreading the disease. Next. This is for males. This is for females, the same group. Again, 25 to 34 are at the top. But also, what do you notice? The very bottom line. For females greater than 55, somebody got to get out there and talk to them about prevention messages because theirs had the greatest increase. Look at this light blue line on the bottom. Can you see my number here? It's going up. Next. High incidence against white males. Look at this. Same group has the highest, but theirs at 50 is remaining almost stable, but going down just a little. But 45 to 54 in their group is decreasing. We got work to do. We have work to do. Okay, next. And the graying globally. And here we see it doesn't matter whether it's males or females. We see as the years increasing, going from left to right, the numbers over 50 are increasing. So we got to be mindful of that because what comes with being over 50 is other comorbidities. Other comorbidities mean other medications. That mean watching out for other complications. Next. Numbers of people worldwide. And we see the highest number here. Again, of those in the darkest colors, again, is where the epidemic is the largest. South Africa has the largest per capita of patients living with HIV. And when we're talking about numbers per 100,000, and we see that's all of sub-Saharan Africa. We look over here, we see South America all the way around. Brazil, the largest area there, is not reported. Excuse me. So, and we see Mexico. We see all of that again. So high incidence all over Africa. We see Europe, Asia. We don't see with China and Russia going on there, not much information. And we see Australia. We're seeing the numbers over 50. It's pretty high. Next. Diagnosed infections, and this is the percent of people who are HIV positive who know their diagnosis, which is pretty darn good. We're focusing on the light blue, which is those over 55 years of age, and we see for that it's about 95%. That's pretty good who know their diagnosis. Okay, but then why is it increasing? Why is it increasing in female in that group? Because they ain't worried about getting pregnant. They're thinking it's young people, and that means that they know diagnosis, but what? That means that they're not taking their medications, so therefore they're not undetectable. And if people need to have this conversation about you, undetectable equals untransmittable. Everybody that comes into contact, nurse, medical assistant, need to be talking with this group because we see those two 45 to greater than 45, less than 10% don't know they have the disease, but yet they're still spreading the disease. So we need to do more education. Next slide. Linked to care. Again, not only do they know their diagnosis, they have an affiliation with some healthcare facility. But the question is, are they keeping appointments? Are they taking medications? Are they getting their labs? Every time you see them face to face, are you getting your medication? And you ask, what's your CD4 count? What is your viral load? You want them to know as to whether they are less than 20 or the term people like to use, undetectable. You want them to know. Next. Viral suppression within 6 months of the diagnosis. We see 60%, but therein lies the problem. They have the diagnosis and they tell us that most people will be compliant for about a year or so, and then they get something called treatment fatigue, something we have to be mindful of, something that's part of pediatric treatment. Children are going to get tired of going to the doctor, giving blood and everything, and they're going to tell you, they ain't going no more. No, you ain't drawing my blood no more. Old people, they just don't come back anymore. Okay? So viral suppression is very good in the beginning at greater than 60%, but we know it falls off because we saw the slides that is increasing in this population. Next. Persons living with diagnosis, and we have the care continuum. And in Black, we have diagnosed, and we're focusing on those 45 to 50. We see that those diagnosed is pretty good all the way across the board. Overall, it's 86%. But we said 92, 95% of those over 45 are diagnosed. We have about 70% are linked to care, meaning they have somewhere that they are going. Retained in care, meaning keeping appointments. A little over 50% keep appointments. Even if they aren't keeping appointments, your question to your cousin, your question to this patient is, are you getting your blood drawn? Because they need to know, 1, CD4 count, 2, are they undetectable? And last but not least, virally suppressed is about 60% in this age in this population, which means 40% are not, which means if they're out there engaged in unprotected sex, spreading the virus. And this is the group that we focus on the 60% so they can study the course and stay in, but we got to get this other 40% in care on treatment and get them suppressed also. Next. Demographics across the United States. And we're talking about the highest incidence of people living with HIV who are over 55 years of age follows the border. What is it about the East Coast? What is it about the Gulf Coast that we have the darkest colors? Then we go over to the Pacific Coast. I think it's in the water, y'all. I think it's something in the sun, on the water, that make people take their clothes off. Well, anyway, we know that we need to focus on this group because we know the prevalence is there. There are about a little over 1 million people in the United States living with HIV, and about 35% of them are over 50%. But we know that now over 50% are over age 50. Why? Because of our medications are much more tolerable, they're smaller, lower number of pills, how we are aggressively out there testing people, trying to keep people engaged in care. So our people aren't dying from AIDS and stuff anymore. They are getting older. But that's the purpose of this, because now we got to worry about the stuff that old people die from. New diagnosis, 37,000 in 2018, 10% were greater than 55 years of age, and mortality, about 15,000 passed, and that was about 56% were those over 50, and if I remember correctly, somewhere around 25% of those 18, 20, 19 died from HIV-related causes. So again, 75% are dying from things outside of AIDS. So this is what we're talking about now. Next. HIV in people over age 55, the proportion that are late diagnosis. All right, somebody raise your hand. What is a late diagnosis? Someone who presents and within 1 year will have an AIDS diagnosis, AIDS-defining illness, or a CD4 count less than 200. Within 1 year of diagnosis, we're seeing 35% of those over 55 come in with AIDS or will have it within a year. This is why we have to be so aggressive about getting them in care. Again, on the left side, proportion linked to care. We said 82%, but we don't keep them. Received care. You get them linked, they're receiving care. We got to do better about keeping them in care and keeping them on treatment, which is those who are virally depressed, about 70%. It takes a team. We have to work together. Next. This was a closer look at Texas. Although this deck came out of Oklahoma, I was a little bit surprised from Oklahoma University, but they put the data on Texas, and basically they were seeing the prevalence there. We said here was about 26.5% were over 55. The incidence, meaning new cases, was about 7% over 55. PrEP use, again, very low in this 55-year and above age, about 7.9%, and 45% of those who passed were over age 55. Again, we need to break it down by those who died from HIV-related versus not, and nationally, it's about 25%. And in DC, in DC, it was about 25%. Next. HIV survival, the way it was when I started, I told you I came in 1993. I started out with 500 patients. I saw 2 to 3 almost every week. I was going insane or more insane. And I had I had a couple dying every month. It was beyond anything I got into medicine to do. And we're seeing that the survival time of the first 500 people diagnosed with HIV was 11 months. And we're looking here by year at the very bottom, 84 to 85, 11 months, 88 to 89, it jumped to 19 months. And by the time we started using AZT itself, it was 17 months. Again, 1990 to 91. Next. Now the good news. And see here, from being diagnosed at age 20, we're seeing the number of years of life left. So in that 1980s to 90s, they had about 8 years. The average one had about 8 years left. with the beginning of our highly active antiretroviral therapy, first with protease inhibitors, then non-nukes, and now integrases, we see it steadily increase to where now a person presenting with a diagnosis of HIV with a CD4 count of over 500, they have a lifespan that's on par with somebody that's HIV negative. So you tell your patient, you don't have to die from HIV even if you want to. Just take your medicines, come back next month, we'll talk about it again. I'm sending you therapy, etc. Just take your medicine. Just take your medicine and keep your appointments. Next. That is great news from when I started here. And look at the death rates. The death rates are still, the slope of the curve, even in 2019, it's not leveling off, it's still going down. Next. And this is from HIV disease. Okay. Again, with HIV disease, talking how good we are at treating the opportunistic infections, getting them on therapy. Again, by age group, it doesn't matter what the age group we're talking about. For all age groups, it is decreasing. Absolutely. And I set my cheat book over to the side, but it doesn't matter what age group we're talking about, that deaths are still decreasing. Come on, y'all, we can do it, but we're doing great, but we can do even better. Next. The changing demographics in this clinic here, again, I told you this is Oklahoma, you see at the bottom, Oklahoma University, this is in their clinic, and this is from 2010, the difference in 2020, and we see here that the young group from those from 20 to 40 is staying about the same. They saw in the beginning in 2010, more people 40 to 50, but now what they are seeing is more people over 50. Again, more people over 50. And this is because they're living longer. A lot of them came in at 40. A lot of mine came in at 30. I still have them that came in to see me. Their children are in their 20s. So anyway, our our patients are getting older, so we have to be mindful. Now let's get into this. So I hope I've convinced you that our patients are living longer and getting older. Next. So it says about 50% of people living with HIV are over 50, and this an increasing proportion of Black, meaning that we're doing a better care about keeping our patients engaged in care. Again, patients, what's going on with patients, they don't acknowledge their risks, especially if they're older than 50. And they're saying older people, they don't see a whole lot of older people before with gonorrhea and chlamydia. We're starting to see them now, especially those old men who are with the young ladies who exchange sex for money for drugs. They're having sex with multiple partners. These old 50, 60-year-old man for $20, they'll make them feel like they're 18. So yeah, so they're contracting sexually transmitted infections. Again, obstacles to being tested is stigma. Obstacles to being staying engaged in care is the stigma. The stigma with sitting out there in the waiting area at the infectious disease clinic or waiting to see Dr. Hubb. Again, he's the AIDS doctor, just all kind of things that get into people's way. I'm going to talk a little bit about that. I wish that we were more close together. And the comorbidities and things going on with them, arthritis, etc. Things, not a comorbidity, taking care of your grandchildren. I have had a lot of women who will sacrifice their health to take their grandchildren to school, keep the ones that's too young, feed them lunch, go get the older ones, and will not come and take care of themselves. Next. This is a talk in and of itself. We could stay right here and be here all day. Each one is a talk. We're talking about why is it that our patients do not stay engaged? We're talking about 95% know their diagnosis. Why is only 60%, a little over 60% undetectable? Because of depression. Why? Because of what? We can really get into that. Because of the yellow one at the bottom, lower economic status feeds into depression. We're talking about financial insecurity. We're talking about home insecurity. We're talking about food insecurity. We're talking about companionship insecurity. We're talking about children don't come by. And when they come by, all they coming by for is what? Grandma, did you make some more cookies? Can you cook me some more of that good fried chicken and fried fish and stuff? But anyway, if that's what it takes to get them there for grandmama to socialize, then we do what we have to. Social isolation. Once they get the diagnosis, they isolate. The lion does not run off into the middle of the pack to grab a wildebeest. He waits for one to get scared and run off to the side and isolate, and that's the one. So no, we do not want our patients to isolate. Adverse clinical outcomes, all of this leads to that. Lower status, lower disclosure status, meaning they're telling less people about their diagnosis. So they're trying to carry this burden themselves, which leads to loneliness, rejection, and depression. We could do a whole talk on this. Next. Rising number of comorbidities here. And it doesn't matter what you look at over here on the right side, hypercholesterolemia, hypertension, diabetes, renal disease. You look along the x-axis and you see as the age go up, increasing numbers have every one of those comorbidities. And what does that mean? That means, Dr. Hogan, I have to know this. And I have to make sure that when I draw their labs, I'm checking their cholesterol, I'm checking their A1C. I'm telling them to hydrate, come in the evening so I can check their creatinine clearance. I got to make sure they, as best I can, try to get them to stop smoking, lose some weight, all these things because of coronary artery disease. And we'll see why I do that. Next slide. Why? Because there's association with HIV infection and developing a chronic condition, not just developing the chronic condition, because these all have demographics. We talked about that, where they location north versus south, risk factors, chronic comorbidities, high blood pressure, diabetes, etc. And this guy, Yang, compared all of these comorbidities between HIV positive as your numerator and HIV negative as your denominator. Next. And what do you see? He looked at them with being positive for 2 years, after 5 years, and after 10 years. And what did you see with HIV as the numerator? We see every single one, 30% increase, 66% increase. As the years go up, the percentage of those who are HIV positive, going across from diabetes, hypertension, stroke, cancer, everything, went up versus HIV negative, which means what? We have to be more vigilant as a team, as the nurse, as the case manager, as the social worker. You know that this person has been positive for 10, 20 years, 15 years. We're saying here that there's an increased probability of these comorbidities, and any one of them can have an adverse outcome. Lung disease, got to get them to stop smoking, even weed. Lung disease. Next. I'm sorry, can you back up one? The last column, cognitive impairment versus HIV negative. At 2 years, 66% more prevalent. This is the one that's going to be in the next 10 years, one of the biggest things out there for people living with HIV. Next. It's statistically significant with association for all of these. I just showed, and I showed you the results at 2, 5, and 10 years after enrollment. So for your patients who've had this for a long period of time, you've got to keep them with their primary care. You got to be looking at their shoulders. And as soon as they tell you someone that's diagnosed at 18, 20 years of age, 20 years later at age 40 and 50, they start telling you that I'm forgetting stuff. They're going to start telling you, my memory isn't as good. Send to neurology. You need to pay attention. I just showed you about cognitive impairment. Next slide. Here we have the prevalence of comorbidities here. And it's, again, this is for people with less than 11 years, greater than 20 years, and HIV negative. And I don't care what you look at, cardiovascular disease, hypertension, diabetes, chronic disease, all of these, every single one, multiples, every single one of them is increased when they've been positive for 10 and definitely over 20 years of age. We have to be mindful of this and make sure that they're seeing their primary care and these issues are getting addressed. Next. Again, cognitive impairment. I got to move a little faster because of time. And what we see here is that for all of these studies except two, there was an increased incidence of HIV positive versus HIV negative individuals having cognitive impairment. And you look at the odds ratio, OR, going down. All of them except one was greater than one. Some 2, 10 times the prevalence. We have to be mindful of those of us who have a population that's been HIV positive for over 10 years, 15 years, 20. Add in drug use, add in alcohol abuse, alcohol use and abuse for many years, plus HIV positive for 10 to 20 years. You got to keep this in mind. Next. Again, this is the same thing, cognitive domain impairment. And the p-value over here, all the way to the right, 0.01 is significant. 0.05 is significant. I'm sorry. 0.01, highly significant for all of them. Executive function and processing speed, being able to think and keep up with stuff, verbal, being able to talk without slowing it, recall, impaired, working memory, motor, being able to put stuff and move stuff around. Every single one was impaired. Everything was impaired. Next. PrEP in our older patients once daily. We have to be more mindful. They don't think that they're being at risk. You have to do this. My patient, 72 years of age, come in dressed to the nines. They told me she went for her birthday with her friends, girlfriends, all of them about over 70, on a cruise. She came back with chlamydia. Anyway, she had fun. Have to be mindful of this. Get our patients on PrEP. You're thinking they're not sexually active. You don't ask. You won't know if you don't ask the question. Again, trying to get them on, not men who have sex with men, heterosexual women. If they have more than one partner, once they show up with trichomonas or any sexually transmitted infection, you need to talk to them about PrEP, try to get them on PrEP. Exchange, it says commercial sex workers. Commercial sex workers, women who exchange sex for money to pay a light bill. Women who exchange sex for money to buy some new tires for their car. Again, you don't want to talk about that, but you need to talk about injection drug users. We need to talk to them about it, about getting on PrEP. Next. Barriers to PrEP. Individuals, low perceived risk. We talked about that. They're afraid of the medicine. You're afraid of medicine or you're afraid of HIV? Which one? Not wanting to take a daily pill. Well, that's coming too. But are you going to show up for a shot once a month or a shot every 6 months? I can't get you to keep an appointment, but once every 18 months, and you're going to every other month. Come on, be for real. Okay? Show me that you can show up. Poor risk assessment, your patients. Limited healthcare access, not a problem in DC. Provider discomfort. Doctors don't ask the question. Doctors want to have sex. Nurse practitioners, PAs, but they don't want to talk to their patient about sex. Come on, talk to the patient. If you're afraid, send them to somebody who will. Costs, perceived costs, thinking the medicine is going to cost them money and not understanding that insurance pays for it. Medical mistrust, research mistrust, HIV, stigma, etc. Again, this is a pill usage of HIV, and you give it to me, and my friends go, I have HIV. So, no, I don't want to do it. Next. Additional considerations, condom use. Got to talk to them when you talk about PrEP or whatever. HIV positive, this entire community that we're talking about, and the ones that we're not talking about. You got to talk to them about condom use. You got to talk to them about condom use, and you got to talk to them about safer sex. Okay? You got to talk to them. They're worried about getting pregnant. They're worried about getting pregnant. So they use less condoms. You got to talk to them. Erectile dysfunction. As soon as the man starts talking to you about medications to treat erectile dysfunction, or they start talking to you about libido, male, females, you start talking about condoms. Talk to them about condoms. Talk to them about condoms, males and females. Okay? Women thinking they don't need it because they ain't gonna get pregnant. Talk to them about condom use, even if you're talking about and PrEP, but condom use and then PrEP. Next. Conclusion. Increasing numbers of our patients who are living with HIV are over 50%. Increasing numbers are over 55%. Okay. HIV, living with HIV accelerates and potentiates a lot of comorbidities. So we have to be mindful. And one of the most important ones that's coming up like crazy is cognitive impairment. I think that is the end of my presentation. Next. So again, resources here. You know, you can always go to the go to my friend Google. A lot of y'all think y'all know everything. My friend Google knows just about everything. Go to Google and Google it and take the time to look up. Don't forget PACE Education and Training Center. But go to Google and there are all of these websites, HIV Insight. There's all of these websites that will help you to learn about what you need to do. Come on, humble yourself. My math professor, my degree is in mathematics, my undergraduate degree. My math professor said, Hogan, don't none of us know all of this, but the smart ones know where to find it. Nobody knows all of this medicine, but the smart ones will humble themselves and try to find the answer. I'll open the floor for questions or whatever. Thank you. Sorry about my voice. I'm allergic to somebody out there. Cut off your camera. I must be allergic. One of you, something, my voice. Cut your camera off and let me see my voice come back.
All right, all right.
Next.
Are there any questions in the chat, Shannon? All right. Well, you can always ask questions. You can also go onto the Effi website, and if you have additional questions, and then at the end, I'll share Shannon's email address and my email address as well, where you can send emails. We also want to talk about the HIV Health Positively Aging program. It improves access to services and care for people aging with HIV through advocacy, education, health services, research, and capacity building. The educational resources addresses enhanced care coordination, health literacy, self-management, and communication between the patient and provider. Through this program, Health HIV runs the National Resource Center for Care Coordination and Positively Aging with HIV. Again, here's the website where you can go and find more resources there as well. I see we have a raised hand, Shannon. While we're getting to the next question, the other website is the other Aging with HIV website, which is capacity building for healthcare providers to coordinate services and data collections and education and resources, enhance providers and patients' knowledge of care coordination for people aging with HIV and co-management of conditions associated with aging. As Dr. Hogan has said, those comorbidities as we get older are really changing. And as a young man over 50 now, I can say comorbidities are real. Shannon, did
Yes.
You don't look a day over 30.
They should be able to ask their question now. Oh, they just muted themselves. Go ahead.
I apologize. I was just letting you guys know that the chat was disabled like for the whole session in case anybody was trying to reply or if he was looking for people to ask questions and stuff.
Okay.
I'm sorry, what was the question? Can you repeat that? I barely hear you.
My apologies. It wasn't a question, just a comment. The chat was disabled through the session. So I'm not sure if like anybody had anything to say or ask questions. I mean, just letting you know, I don't know if you guys were aware that the chat was disabled. I was just able to get in the Q&A part, but no one was able to,
Oh, wow.
ask questions.
We do apologize for that. And you can go into the Q&A and ask questions in the Q&A as well, if there's any questions. And again, if you have any follow-up questions, Shannon and I will definitely be able to answer the questions and get the information to you. And if there are any additional research you would need, we definitely can make sure that that happens as well.
And if you can send it to me also. Any questions?
Absolutely. And if there's any questions specific to Dr. Hogan, we definitely can, we will definitely forward the questions to him, and he can respond as the provider and the expert in the area of HIV. And it's an internal medicine provider as well. So he can answer other questions as well when it comes to your medical needs.
Someone asked if there was an outline available, but we will send out the slide deck.
Yes, the slide deck will be sent out, and it will also be posted and uploaded onto the Effi website. Moving forward, we're revamping the Effi website, so you'll see a whole new library of different webinars and trainings that you'll be able to access. We're in the midst of doing it, so give us a couple weeks, and we'll have all the additional ones along with this one up on the site. With this one, Shannon is going to be putting into the chat now the link to the survey, and she will also be sending out to all of the individuals who participated who for CEUs. She'll send the instructions on how to access it and download your certificate for CEU credits. And if there are no more questions, I would like to thank Dr. Hogan again for this amazing presentation. Health HIV, love working with you. You are always one that, really come in and really give it straight to us, and also are always available to make sure that, presentations and information is being put out into the community, and we appreciate you wholeheartedly.
Thank you. You're welcome.
All right. And with that being said, we thank you all for participating. And until next time, be looking out for some of the new and upcoming trainings and webinars that will be coming out through the Effi Institute. Thank you, and have a great rest of the day.
Thank you.